Welcome to the 5th Indigenous Mental Wellness Town Hall presented by the Wsth Radio Network. We have another great show for you with guests Bonnie Healy and Patrick McLean. Hosting this session is Loa Beebe.
Thank you, Oki, and welcome. Thank you to all of our listeners on the Wsth Radio Network joining us today, and all of those that are joining us as well on Facebook. Please go to the messaging feature for the CFWE to send us questions. And for the next hour and a half, I'll be your host. And today we are speaking to Patrick McLean and Bonnie Healy, two team members of study published in the Canadian Mental Health Association Journal, and showed us First Nations people were treated with less urgency in emergency care. Again, if you have any questions or comments, please leave them in the chat on the CFWE Facebook page. I would like to welcome our panel today. And first of all, I would like to welcome Patrick McLean. He holds a PhD in sociology from the University of Alberta and is the adjunct associate professor of emergency medicine at the University of Alberta. He has developed a mixed methods program, research examining equity in emergency care. He is employed through the Alberta Health Services and assistant scientific director of the Emergency Strategic Clinic. Patrick, at this time, if you can share some opening remarks and introduce yourself to our listeners.
Yeah, well, thank you, Loa. As you said, I'm Patrick McLean. I'm a researcher working with health services. And so I'm non-Indigenous. I'm a sociologist, as you said. I'm not a physician, but I have the good fortune to work with emergency departments on quality of care issues. And so I'm a settler in Treaty 6 territory here in Edmonton, Métis Region 4.
Thank you very much. And at this time, I would like to welcome our other panelists that I'm very honored to have today as well. Bonnie Healy, she is the health director for the Blackfoot Confederacy. Bonnie, if you can please introduce yourself and share some opening remarks.
Okay, Loa. Okay, Nistoanago Kapoyaki, Nimtodoa Ganai. My English name is Bonnie Healy. I'm a Blackfoot member of the Kainai Nation in Southern Alberta. And I currently work as the health director for the Blackfoot Confederacy. Much of my work and my background is in nursing. I'm a registered nurse and have been working as a nurse, I think, since 3 decades. Will not age myself, and much of my career has been in hospital settings like the ER. I'm a trauma-trained nurse, worked down in New Mexico in Albuquerque as a trauma-trained nurse, and worked for about a decade in the Vancouver's downtown east side as a nurse running a mobile street van for the population in that area. Also worked in many hospitals, including U of A, Foothills, VGH in Vancouver, and UBC in psychiatry. So worked many years in those settings, as well as public health for the federal government. And of late, my focus has been on data and research. I'm the former chair of the First Nations Information Governance Center, and my previous role was the executive director of the Alberta First Nations Information Governance Center. So this is where I got to meet Patrick.
Thank you very much. And before we start, I would like to acknowledge that I'm joining today's discussion from the city of Calgary, which is the traditional territories of the Blackfoot Confederacy, which includes the Siksika, Piikani, and Kainai First Nations, the Stoney Nakoda, comprising of Chiniki, Bearspaw, and Wesley First Nations, and the Tsuut'ina Nation. Today, this territory is also home to the Métis Nation. While we meet today on a virtual platform from coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So at this time, I just want to give a little bit of a background on the town hall that we're having here today. It is on mental wellness. Our focus today will be on the systemic and discrimination racism that Indigenous people across Canada actually feel in the healthcare system. And we're honored today to have two people that have worked in the field and that are doing research today, and they're going to share some of their findings. I would also like to acknowledge the WinSpeaker media team and staff for getting today's show prepared and ready. I'd also like to acknowledge our First Nations in Inuit Health Branch of the federal government for also hosting. And we also have a steering committee from Treaties 6, 7, and 8. So I'd like to acknowledge those people that work very hard in their day to day to actually get today's show ready and hosted. At this time, I will go back and forth in the same question, and please feel free, our panelists, to even just add something or to go back to a question if you feel you want to. And we do have an hour and a half today, so we definitely will get very deep into our questions, and please feel free to even ask other questions or bring up other topics as well. So thank you for that. And I will actually start off with Bonnie. And Bonnie, in the research that you've been doing, can you talk about some of the studies that you and Patrick have both worked on, and what prompted this study, and how did you get involved?
Thank you, Loa. When I was working at the Alberta First Nations Information Governance Center, I got a call from Patrick asking if I was interested in this work. And at the time, I was doing some extensive research on cancer. So some of the work that early studies that I had participated in at the AFNIGC was really looking at cancer incidence rates for Indigenous populations in the world. So we looked at 4 countries with large Indigenous population groups, and that's the US, Canada, Australia, and New Zealand. And we pulled the data, and unfortunately in Canada, we didn't have access to a First Nations cancer registry, but we did have access to a First Nations cancer registry within the Alberta Health Data System. We were able to identify First Nations in Alberta because from 1999 to about 2009, First Nations paid into a health premium. So we were able to identify First Nations in the administrative data, and the linkage to develop a First Nations cancer registry was available. When we looked at that study, it was with the World Health Organization, and it's published in the Lancet Oncology Journal of October 2014. You can look for some of the findings. From there, we started to look at cancer in Alberta. Then we focused on screening data. We focused on the HPV vaccine uptake in our communities that prevents cervical cancer. So we looked at high incidence of cancer in that data system and started to look at other studies and do a lot of research in that work. When Patrick contacted me, one of the pieces that was quite troubling for us is when our individuals were discharged in palliative care from the cancer centers to the communities, there was not a direct way to communicate with the nations because they're not recognized as a health service provider in the health matrix of service delivery. And that caused a lot of problems. If you could imagine being sent home on a Friday and nothing set up for you, IV care, morphine drips, etc., to be able to do palliative care effectively at home and to be comfortable. So when Patrick approached me, a lot of our individuals were actually showing up in the ER over the weekend from these in crisis because the system was not set up for them when they got home. So I was not only interested in the work, but also interested in really understanding racism from an Indigenous experience. So when we met, I had spoke to Patrick about, I'm not interested in looking for racist individuals in the system. I'm just looking for the system itself on how we can ensure that our First Nations people are treated in a way that that they went there for. They went there with a concern that that they're seen and they're connected to a treatment pathway that they're able to get the care that they sought out in the first place. Being an ER nurse and being a trauma trained ER nurse, I know the stressors that are in those systems, and I know how it can impact you as a human being when you're exposed to many traumas and tragic loss of life, and how important it is to do self-care. So we were going to really gather the data and really understand the stories from an Indigenous experience, and where we could have individuals share their story in their language. So really do a wholesome understanding of their experiences in these spaces. And so Patrick can speak more extensively on that. Thank you.
Thank you very much, Bonnie. Patrick, I'll have the same question for you. What prompted this study and how did you get involved?
Yeah, so when I finished my PhD in 2015, I worked in health research for a few years after that. And in my PhD, I'd been interested in racism. I think it's one of the key issues we need to tackle if we want to live in a just society, which I certainly want to live in. And so when I started working with emergency departments, the case of Brian Sinclair it had happened a few years prior, but was very much in my mind. He waited in a Winnipeg emergency department for, I believe it was 32 hours without being triaged or treated. So that was very much in my mind. So I reached out to Bonnie to start talking about what a project could look like. And yeah, I think we had some initial conversations going back to 2017, I think, when we started, and really developed a project together where we said, okay, what could we do to look at this issue in a really good way? And Bonnie involved a number of other partners so that it wasn't just me as a settler researcher trying to do this. So we, Musqueam's Health Services, Yellowhead Tribal Council, the Treaty 8 Organization, Blackfoot Confederacy, and the Stoney Nakoda Tsuut'ina Tribal Council have all been part of the project and are part of the project, along with AF and IGC. So Leah Bill there is now co-leading and leads a lot of our qualitative work. And so we really wanted to put together a project. Can we look at, like Bonnie said, what are people's experiences? Interviewing physicians and nurses, and also talking to patients through community sharing circles. And alongside that, do the statistics. So the article you mentioned that's published in the Canadian Medical Association Journal, that's a more statistics article, but looking at if we put the picture together with those different sides from what are people's stories, and then using those stories to understand the statistics we would see in emergency department visits and outcomes. And then going forward to think, what do we want for quality of care? And so have First Nations people start to set definitions for quality of care in emergency departments.
For sure. Thank you very much. I just want to give some background for our listeners in the sense of racism in healthcare. I think we're at a point in society, 2022, and for Indigenous people, it's been our lifetime, that nobody can deny today that systemic racism and discrimination exists. And I think I'm very hopeful that studies like this, and it's really nice to hear that you have a whole group of people in Alberta from Treaty 6, 7, and 8 that do want to tackle this. And you're including the healthcare system as well. So you're including physicians, nurses, and those that work within the field. And I am very happy to hear how you came about it. It's sad that you're actually having to point out a problem and this is what you want to do. But at the same time, it's moving the needle because the needle has to move. The needle has to move in a certain way. And I think Canadians, a lot of them, when it came to Joyce Echaquan and her story, and I remember being at a conference that month, and it happened a couple of days, and Bonnie can remember this, it happened a couple of days before that conference. And it was, on harm reduction. And it hit Canadians very hard. And these are realities that we live as Indigenous people in Canada. And Joyce Esterquan, she was 37 years old in September 28th, so 2 days before Orange Shirt Day, which is now also the National Truth and Reconciliation Day. She passed away in a hospital, and she went Facebook Live, and the healthcare professionals that were there, and then the nurses, there was definitely abuse that was happening, and she passed away in that care. So it is very sad, and I think all of us we don't want to see these types of stories before change happens. We also want to make sure we're working together. So when I talk about this, and the next question that I have is, what in your studies, if I could hear a little bit about what shocked you, because we do know the Joyce story and some other stories, and then our own experience. So I'll go to Bonnie, and Bonnie, if you wanted to even just elaborate on some of the thoughts there.
Well, and I think, Loa, you captured it in a fairly good way. I think, unfortunately, nothing really shocked me because I worked in those spaces. I heard those comments. Even myself, I think I can count on one hand how many times I've gone to the ED department for my own care. But I think I gained a deeper understanding. The majority of individuals that work in these spaces, doctors and nurses and health system providers included, because I talked to all levels. I talked to a physician's group within AHS about some of these issues and concerns, and to address the health outcomes of First Nations. So when I worked at AF and AGC, one of the things that I did early on was to gain some understanding as to the health inequities or the health outcomes. So I produced health trends. I first looked at life expectancy, and to see that First Nations in Alberta had the same life expectancy as individuals in Guatemala, Paraguay, and Cambodia, whereas non-First Nations in Alberta have life expectancies of people in Australia, and Singapore and Sweden. And so in order to talk even gap closure, I needed to understand these health inequities and try and understand how they were all being addressed and why. And so one of the things that shocked me is even the high levels of system providers that oversee legislation and policy do not understand how health services are provided on reserve in the community. Majority, I would say 100% of them did not know that we do not have fully funded primary care networks. So we are utilizing the emergency department like it's our family doctor. And this is, where you see large volumes of Indigenous people that are in these systems because they don't have family physicians in their community that are fully funded. And we don't have primary care networks. So if we had a fully funded primary care network in our systems, in our health service delivery models on reserve, we could mitigate or, prevent a lot of disease processes progressing, like, for individuals with diabetes, we could delay or work with them in a care plan way to ensure that they don't enter into dialysis, that they don't, progress to amputations, all of these, preventable progressions of this disease process. But we do not have those primary care networks in our communities. And a lot of individuals, service providers, and I've talked to public health physicians, residents that are specializing in public health at the University of Calgary. They do not know how First Nations get funded to provide some health service delivery on reserve. And so the only piece of policy that actually funds or ensures that we can deliver services in our communities is a very racist piece of policy that was written It took 100 years to write it. It was established in 1979, and that's the First Nations health policy. It was written because settlers saw the deplorable conditions as we were put onto reserves, like smallpox, TB, Spanish flu, etc. They did not want those diseases crossing the fence into their jurisdiction, so into the settler community. So they lobbied government to ensure that the diseases stayed contained within the fence. So what the service model looks like as service delivery on reserve is surveillance and CDC control. So controlling disease in the confines of the fence. So what we fund well and what we do well is vaccination programs, surveillance of TB and other diseases. We don't do a lot of prevention care. We don't have funding for primary care networks. So those are important to understand as to where does systemic racism come from, because it's mentioned in the Treaty 6, and I can't speak to it because I'm not a Treaty 6 member, but the medicine chest clause is really important. And so upholding those promises that our ancestors entered into these relationships to share the space of this territory in that treaty right to health, that is not recognized in legislation in Canada or in the province. And so we're still trying to work with the service providers to understand how they can, as allies, uphold the treaty right to health. And in the Blackfoot case, we were very healthy people before colonial interruption. So returning to our Blackfoot path as much as we can in this current context of these relationships. Get back to those early settler descriptions of the Blackfoot people, very proud, very highly sophisticated people. Maslow tried to write about it in his hierarchy theory. And I think one of the descriptions that's quite something that stays with me is we were described as lean and sinewy people. So there was not a homeless person, a beggar to be found, no obesity, very healthy people. And so trying to understand how we can get back to that and looking at all of the areas where colonial interruption is interfering with our path to be Blackfoot people. And the closer we get back to who we are meant to be, we'll move back into that healthier Blackfoot person that was described in the early settler days.
Thank you very much, Bonnie. I do really like the historical aspect that you're talking about as well. We were definitely, our lives and everything about our lives were different pre-contact. And so thank you for that. And it's nice to even hear how they captured it, those that were visiting here, to understand and see, how we're a vibrant community. So Patrick, at this time, I want to ask you the same thing. What outcomes of the study were most shocking to you?
Yeah, and there's probably more that surprises me than Bonnie, since I don't have the lived experience of racism. And sometimes we hear from partners when we present, why are you studying this? We all know this is true. I think some value in studying it is putting it on the record. So putting it up, open access, it's in the journal, so it's part of the record. It's not an internal report that's going to get taken down, and really documenting. And I think our process for research has been good. But so some of what we found is we looked with the Alberta health statistics, which have some limitations, but for those statistics, we saw that Status First Nations persons make up almost 10% of all the emergency visits in the province for the 2012 to 2017 period we looked at. So 9.4%, and that's only Status First Nations persons. So it wouldn't be non-status persons, it wouldn't be, so Métis would be a different Indigenous group that we wouldn't have records on in our data set. people who come from other provinces or from the territories and receive care wouldn't be captured there. So this is a real, even this really high number of 9.4% of the visits are First Nations people. That's an underestimation of how many Indigenous people are actually using the emergency department. So I think that was probably higher than I thought it would be when we started the research. And I think it really shows the importance of emergency care as a service for First Nations people. I think it helps show that emergency departments need to be thinking about how well they're serving Indigenous people and raise the profile for that work. We've also seen there's 4 hospitals in the province where actually the majority of emergency visits were by First Nations people. And so we've been able to give a list of what proportion of visits in each hospital are by First Nations people to First Nations partners. We haven't made that publicly accessible on a website, but we've given it to First Nations organizations to use. So it could be for advocacy, for saying, look, we do need more primary care, look how much we're using the local hospital, or to say, you know, if we're most of the visits at this hospital, what's our role in governing the hospital? So I think that's some of what was an initial finding. Maybe when we looked at triage, we also looked at, we hear people have been saying a long time that First Nations people aren't taken as seriously when they come to the emergency department. So we looked at triage, that process where the nurse takes a medical history and looks at presenting signs and symptoms to determine. It's supposed to be based on medical needs. So it's supposed to be equity based in sort of the first place, this idea who needs to be seen fastest to have the best outcomes. And so when we did look at triage, we saw First Nations people are less likely to be treated as the most urgent patients in the emergency department. I think it's been valuable to do that analysis and document that. And it could be partly due to lack of primary care, as Bonnie was talking about, but we also wanted to see, so if we looked at specific diagnosis, so we picked 5 diagnoses that the elder advisors for the project suggested we look at. And so people who get the same eventual diagnosis, are they triaged to the same level of urgency? And for 3 of 5 of the things we looked at, First Nations people were less likely to be treated as the more urgent patients. So those 3 things were long bone fractures, like a big bone break in your leg or your arm, acute respiratory infections, and then people with who are in the end diagnosed with anxiety disorder. So for 3 of 5 things, even though the diagnosis is the same at the end, the triage across the millions of visits that we looked at, 11 million emerge visits that we looked at, the triage is not the same. So I think that helps back up what people have been saying, that there is this inequity in care.
Thank you very much. You know, when thinking about this, is something that Bonnie had said, when you look at the historical aspect of this, I'm really thinking the structural part of this, just the structure itself, it starts at a higher level. It's not necessarily, it's everywhere. It's when you walk in, it's within the system, it's a structural, it's an institution. There is also the healthcare professionals themselves, you know, that have these biases, and there's overt and covert racism, you know, that exists as well, that our people are facing. And it's really nice that you have, you know, millions of visits that you actually measured, and that this work will work towards changing something. So I want to give both of you, you know, there's no words I can actually say in thanks of this. You know, I have, we all have family. We've all definitely individually have experienced racism in the system. What I do like about it now is similar to the residential school and day schools. I can actually state today, I am experiencing this in the system. You know, I actually am now even saying, when I walk out of my place, I experience racism. You know, and before it, when I was growing up, and Bonnie, I don't know if your experience is the same, we were strong enough to overcome it, and it was kind of silent. And I think these numbers and the research that you guys are doing, and so many stories are coming out, that it's something that can't be ignored. It has to be tackled, and it has to be, something has to come out on it. And so we're here today, and I just want to ask both of you working in the profession that you're working in, are you hearing more about this discussion? And also add some thoughts to that, and I'll go back to Bonnie.
Yeah, I think it's ongoing and it's everywhere, and it's with, I'm still very closely connected to researchers that are Maori or Aboriginals from Australia, and a lot of my US colleagues that work in this area of research. And we really work together, because we're addressing similar things, but from different perspectives of relationships from their country and their relationship from their country. But I think one of the things, like you saw it with Black Lives Matter, where COVID really highlighted the issue of mistreatment of Black individuals, especially from the police and the racial profiling that goes on with them. And we saw it too in this with COVID. So when Patrick and I pulled the data for the first phase of COVID, we started to see a lot of the gaps and inequities in triage scores. And I think, as we have more of a closer look at things and really understand how it's impacted from the individual providing care and the individual receiving care, and really looking at the data, and it's not just about cultural awareness or cultural understanding. That's part of it, the creation of allies, and allies that really know their role. So, Patrick is an excellent example of what an ally looks like. An ally does not, proclaim to be the expert of everything Indigenous. Now that they've done this one piece of research, they really know how to be there in that space and to facilitate the conversation and listen intently and respectfully, and work, in that guided conversation, but lend their expertise, especially looking at qualitative data and the administrative data set, and bringing us all together to have this really difficult conversation, but with great kindness, compassion, respect, and understanding and honesty, and not trying to be defensive or have answers for those, that are causing harm, right? But just listening. And I think as we move into more research, that are really led by the First Nations themselves, and community led and community driven, and rooted in their Indigenous research methodologies, and work together with allies like Patrick, to get this work published. This is, I think, been tried in the past, but you see this huge movement of Indigenous research that is really helping to find solutions. I know that, I hear from many of our people in leadership that research in the past has caused a lot of harm, and we've been the most researched people in this continent. And I think I've even heard the term research to death with no change. And Dr. Cora Voyager gave me a term. It's like, yes, we've been researched to death, but now as First Nations researchers, it is our responsibility to research ourselves back to life, and to ensure that we create that change in those spaces and really identify the root of those harms. And so that's looking at legislation, that is interfering with our ability to be Blackfoot, in my case. And at the end of the day, my wish and my dream is to be Blackfoot without interference, and identifying where interference occurs and where it causes harm, and that I can't be true to who I'm meant to be as a Blackfoot woman. And I think as we move more into those spaces and become truer to who we're meant to be, the healthier we'll be as a people. And I'm grateful to allies like Patrick and others that I've worked with, to be able to have voice, and voice that can't be mitigated or discredited by government. And so, looking at racism and hearing the stories in the past, government could ignore it because it's anecdotal complaints, one person at a time. This is a collective voice, and it's very, very loud. And we're forced to look at it. And, grateful to those that are working in spaces, both, in the system and in government, that want change as well. And so, we'll all work together in partnership that's respectful to ensure that change does happen. So thank you.
Thank you. Bonnie, I really like listening to you talk all the time. And what I want to say and just take from what you just said is working together. And I think that's, if you go back to the historical aspect, we are somebody who used to work together. All of our communities used to work together, even if you were from a separate tribe. There was definitely a cohesiveness and trading and that type of thing. And I also want to thank you, because I've known the many years in your career where, yes, we were not the researchers. And you have forged the way in educating people why it needs to be us researching ourselves, why we need to be included, why we need to have authority in doing that, and those types of things, and why we own our own data, and why those cases are the way they are. So I want to thank you again, for all the hard work that you're doing and helping people understand and educate. And in saying that as well, and when you talk about leadership, I'll say it's very hard, even in leadership, a lot of the leaders that I've worked with closely, is they have much on their plate as well as doing this, right? And then you add this aspect, now we have allies in the group, so you add this whole aspect in order for us to come out of this, and Cora Voyager is one of those as well, that has been in the field for many years. So I want to add that aspect in some of the story that you're telling, is this is a totally holistic aspect, and how are we going to move forward from here? So, and I know too, and I'm always stating that people are not given their due. So I'll say today, I don't know how many compliments I'm going to give you, but thank you. Thank you for that. And I'll go back to Patrick. And I know, Patrick, you had said in 2015 there was a story that made you look at this and understand it a little bit more. From 2015, it's now 2022, and even in just the work you're doing, can you tell me a little bit more about what you're hearing about this issue, and maybe even how it's changed a little bit in this short time?
Yeah. I think there is a lot more emphasis on this issue. I think we ourselves have done a lot to put it on the agenda for emergency departments. I'm just so privileged to get to work on this topic, and yeah, it's been probably really transformative for me in ways I probably don't even realize yet. And I'm always grateful to be called an ally, and I don't know if I think of myself that way, but I want to do service. I want to have work that I feel is good work, and I recognize what a privilege it is to be able to work on this topic with people like Bonnie. And yeah, so are things getting better? I think there's more and more emphasis on issues of racism. I remember when we started the project, people at Alberta Health Services, I think maybe because the CEO, Verna Yu, is really willing to talk about racism and not sugarcoat it or change the language to talk about cultural difference or something. I think people at Alberta Health Services sort of even got it at the beginning, but other academic researchers would say, oh, can we really talk about this? Can we research racism? And we always started from the beginning that, okay, there is racism, and we'll see what it looks like in emergency departments, as opposed to trying to prove whether it does or doesn't exist. But I don't think those conversations are the same anymore. I think people are saying there is racism and we need to address it. And so there's a lot of work. Indigenous wellness folks at Alberta Health Services, I think, Dr. Esther Tailfeathers is the senior medical director there, and I'm just in awe of Dr. Tailfeathers. So I think there's things changing and a lot of reason to be hopeful right now, even though what we're finding is really disturbing. I think we don't want to discourage anyone from coming to emergency departments. They're open for everyone. Yeah, I think there's some reasons to be hopeful that things are going to be getting better, and we hope we're part of informing that.
Nice, thank you very much. I want to go back to the story you had talked about, Brian Sinclair. It wasn't 2015, it was 2008. So September 2008, and he was 45 years old. Actually, his physician in primary care referred him to the emergency. So I'll just give a little bit of background on this, because that leads into my next question. So that was only a few blocks away, and he was actually put in a taxi with his wheelchair, so an ambulance wasn't called for him. He was then put in the hospital, and he was in an emergency, and he was ignored, unattended, and uncared for 34 hours. He died of complications of a treatable bladder infection. So that was quite shocking. The government and others, they were pressured to do an inquiry. Instead, they did an inquest, and it took 5 years for that to start. So it took 5 years for that to start. And in January 2014, the inquest presiding judge ruled that issues of race, racism, poverty, disability, and substance abuse were beyond the mandate of the inquest. So, so those types of stories are happening today, in Canada. And so when I talk about this, I don't know if there's anything that, one, was shocking to you, because this is Manitoba, was shocking to you in the study that you were doing, and two, if there's a story or something that may personally have happened, and that's for Bonnie, to yourself within the system, if you would like to share that.
Sure. I guess maybe I can go first, Patrick, because
Yes.
Patrick and I have had many conversations on this specific case. And being an ER trained nurse and working in those settings, and I worked in Albuquerque, and it bordered on the Mexican border, right? And a lot of my clients actually didn't have insurance. And when you actually try and get care in the States, there's now laws that are passed in the US that we cannot turn anybody away or refuse care because they're not insured, that we still have to provide care. It doesn't mean that changed how individuals that are living in the US that are, not US citizens or they're illegally, the way that they approached triage was very startling to me. When I worked down there, I had a individual, she was pregnant and she waited to the last minute, so no prenatal care. And she pulled up into the emergency, I guess, front of my triage door, and had delivered the baby in her pant leg. And so I, the triage nurse, ran out and, got her into the ER, got her into the trauma bay, and got all the appropriate physicians, OB and gynae in there to take care of both her and baby immediately, so that, we didn't lose either of them. And so when I was listening on the Brian Sinclair case, and what shocked me and what appalled me the most was how much the system spent to prove that racism wasn't at play with Brian Sinclair. And what appalled me is that the system actually didn't look at the teams that were scheduled in, or the triage nurses that were in those spots, to say, why did all these shifts within this 34-hour period not see this individual that was sitting in their waiting room? If I, a triage nurse, can go into the parking lot, get a baby that's in a pant leg of a woman, why could they not see this individual? Even though there was an individual, a mom that was there with her sick child that had approached the security guard a couple of times because she went in there on 2 different time periods and noticed he was getting worse. And the security guard met her with a conversation of saying, he's just sleeping it off. Now, whatever that meant, we kind of can make the assumptions of what that comment meant. And so where I'm appalled and disgusted, as a nurse, I prided myself in knowing every man, woman, and child that was in my waiting room and knowing what care that they were there for and how quickly I was going to get to them. That disturbed me that none of the individuals that were service providers actually came forward to say, yes, he was in my waiting room, and I'm ashamed that this person lost their life because I did not go out and see what they needed or what their state of care was. So I'm not the one who has to sleep at night and answer for that death. But, you know, as a nurse, as a ER nurse, as a very good triage nurse, I was excellent at that role. And most ER nurses don't like that role, but we'd all run to put our name down, you know, at the start of the shift, and nobody wanted triage, but I was the first one whenever I was on to put my name in triage. And I think that bothered me the most. That did bother me the most. It's not about proving racism. It's about understanding why this person wasn't seen in a waiting room, in an emergency room, and wasn't cared for. I think that bothered me, you know, and still does.
Thank you. Thank you for that. When you're talking about that as well, I think about how the system protects these people. And that's what we were talking about a little bit earlier. You know, there's no accountability for, you know, actually figuring out what is the truth here. You know, the system is actually protecting and allowing people to state that it was not about this, it was not about that, and really passing the buck, and no one really took accountability. So that is what's very shocking as well. Thank you so much, Bonnie. I wanted to ask Patrick, is there something else that you wanted to share about what was most shocking to you, a little bit more about even some of your research there, and then I want to move on to what do people experience when they come into the emergency?
Yeah, I think, you know, we were talking just a little bit before about what's changed. And I think, so Brian Sinclair occurred in 2008. And then, you know, we were still thinking about it when we started our study in 2017. If you look at the case of Joyce Echaquan, in that death, the coroner was willing to say that racism played a role in the death. So the Quebec coroner was asked by the media, would Joyce Echaquan still be alive if she were white? And the coroner said that she thought so. So I think that is a difference in the discourse, and maybe a reason for some hope in improvements to come. But I mean, Joyce Echaquan was just last year. I think, yeah, it's hard to think that this is still the situation so often. So maybe that's the most shocking, is that we still have that new case to talk about.
Mm-hmm. When I think about what actually happens to people when they go, Indigenous people specifically, when they're seeking health support, one, I want to say from our side, and including myself and including family members that I know of, that's the last place that they're wanting to go, is to the emergency. And I actually had an ambulance driver very recently ask me, is there a reason this person does not necessarily want to go to the emergency? Did they have a bad experience? And I said, let's be honest here, our people experience racism. And he agreed. So I'll say as well that I definitely am seeing that as well. And then I thanked him. I said, thank you for asking that question, because that is a real question, and it is a real thing that we experience. So even myself, I will not sugarcoat or deny things. And I think more of us need to do that, because there is definitely, there's a denial of access and resources that we receive when we go there. There's many things. So what I want to ask, and I'll go to Bonnie, when an Indigenous person goes to the emergency, what are some of the things that an Indigenous person would experience as compared to a non-Indigenous person? So we could just let our listeners understand what the difference is.
Well, and I'm only going to speak from personal context, because I think I can't make the assumptions for others, but I've had others come in or come to me with concerns and share their stories. So I won't speak on their story specifically, but when Patrick and I were trying to include the word racism in this work, and it was met with some resistance. And I said, no, you don't understand. We're not actually trying to prove racism as at play. We're not trying to witch hunt and look for racist individuals within the system. What we're really trying to understand is the experiences individual people are feeling. And so I wanted it understood in language. And so the only thing I could actually compare a Blackfoot word to that and gain that understanding, I didn't want to look at it just from a colonial context, just from Western indicators. I didn't want to look at it from the word racism itself as an English word, because the English language is very easy to manipulate, as we saw with Brian Sinclair, and how the legal system and legal context can manipulate English language to prove something isn't there. And so my example is always with racism or something like racism. Western systems and Western science need to prove or measure it to prove it exists. And so with racism, and if you looked at it only from an English context, how do you measure a dirty look? If you can't measure a dirty look, are you saying racism isn't at play? So this is where I wanted to understand it from an Indigenous language concept. And so the Blackfoot equivalent word would be istikanapi. So that means my dirty looks, my wishes, my desires, my thoughts, my tone, my, I guess, intent is to harm that human being. And so there's accountability built into our Indigenous languages, like in Blackfoot. And that one word can describe all of those things, as that is my experience. That is what I'm feeling, right? And that's how I wanted the individuals to share their experience in a real context of understanding. And so our purpose was not to discredit them, not to gaslight them, not to sugarcoat it or be defensive for the individuals that made them feel that way, made them feel harm. It was really to just gain an understanding in their languages where they could explain how they felt in this space. And so I think we did a really good job at understanding that. And that was the rationale for it. It wasn't about only using a Western worldview to tell this story. It was important that we told it from an Indigenous worldview and told the narrative from and understood it from that way as to why Western systems have limitations, and where Indigenous worldviews can add more context, and there's accountability in our languages, and there's honesty in our languages that cannot be changed or manipulated. They're very, very clear on the intent. So I think when we look at these hard concepts like racism, the only advice I would give to individuals that go into these spaces, and what I'm going to do as a Blackfoot woman, I want to be respected as a Blackfoot woman. And I will give the respect and kindness, even if you're not behaving properly. But I will tell you, you know, when you are. Just recently, I had to be the advocate for my infant great nephew, and he was sick, I think, from August until October, and seen almost on many occasions in Pincher Creek ER. He had seizures, he had low-grade fevers, he had all of these things. His eating habits changed, and by the time, you know, I'd been trying to support the mom in his work, and he then was last seen in Lethbridge just, I think, 2 or 3 days before Halloween or after Halloween, and he was found to have a severe iron deficiency by the pediatrician, and the, you know, the doctor and dietitian blamed his iron deficiency on his young mother, and basically accused her of not feeding him properly. And when he came into my care, because they had a death in their family, and so we were caring for them that Friday night, it was 2 days after Lethbridge saw him, he was almost gone. He was so listless and lifeless, and you know, was puking up bile. Nothing was in his body. And I'm gonna get emotional. I'm trying not to, but I packed him up at midnight, and I told my 74-year-old mother, we're going to Calgary, and we're going to take him there. And he was very, you know, easy to bring. It was like such a peaceful drive. And we were admitted within 5 minutes of being there, you know. And I was grateful that I could use my nursing and trauma room experience to advocate for him to get care. And he was admitted. He was seen by 3 different pediatricians within the 2 hours that I was there with him. And I had one nurse tell me, well, you know, you have tremors when you have fevers. And she started to do these body things and talk to me like I was a child. And I lowered my glasses and I said, I am an ER trauma nurse of 3 decades. I think I know what a tremor is. And she backed out of the room, and she was very apologetic. And then she peeked her head in the door and she said, the next individual that comes to talk to you will talk to you like you're a nurse. And I said, okay, thank you. I do not like to do that. I do not like to have to pull that card. When I walk into those spaces, I never tell them I'm a nurse. Never. Until they meet me with disrespect. And if I have to advocate for whoever, myself, or in this case, my infant great nephew, so that he gets the care, as it turns out, he had a very rare disorder. He had a blood clot in his brain that comes from the genetic of one of his family lines. And there's 1 in 5 million in the world that get diagnosed with this. And for children, it's 1 in 350,000. And I knew getting this diagnosis was nothing short of a miracle. And it was like a needle in a haystack. But, you know, from those 3 physicians that interviewed him, one of them decided to do a CAT scan and found it. And for that, I'm forever grateful, because he is healing. He's on his way to full recovery, and this will not interfere with the rest of his life. But if we don't listen to, you know, especially infants, you know, that can't speak for themselves, and young mothers, you know, that are struggling and afraid, you know, like, and if it, not everybody has a Bonnie in their family, you know, not everybody is going to have that advocate, and we shouldn't have to. That's what those experts are in that space for. And that's all I'm asking is, some of these things are really impossible and hard to find, to ensure that life is not lost. And let's just remember why we went into these careers in the first place. What did we want to do to help people? What was our purpose to be a nurse? What was our purpose to be a doctor? What was our calling? What was our initial desire to do that? And not forget it, not go through life and let life get in the way of really understanding what your true spirit and intent was to begin with, to become that care provider. And always stay close to it, because that should be your guiding force. And no harm should come to anybody under your care, wherever you can actually, have any kind of control over it. And we cross that stage and we gather our diploma and we put our hand on a Bible and we actually make those commitments that no harm will come to anybody under our care. And we forget about those when we're in these spaces, but we shouldn't. They should always be close and near and dear to our hearts.
Sure. Thank you very much, Bonnie. And I really want to thank you. There's no words that could express how thankful I am for everyone that has come on our mental wellness town halls that have shared personal experiences. And, one of the questions I was going to ask, and maybe I'll go to Patrick, and if there's any other thoughts, Bonnie, if you want to add after Patrick goes there, is how do you feel that these types of experiences affect Indigenous people? And it's very clear that these stories, like I just told a little one from this month in my family, and with people that I know, we are ready at any time to be an advocate for our people. All of our families rely on those people in our within our families to be an advocate. We definitely, I also like that you said, I waited and I don't like to pull that card. And I think we all go into scenarios where we are waited to be treated fairly. We all know and have a feeling when we're not being treated fairly. We have an instinct for that. And that is something that is real for us. There is also a lot of stress that comes from that. As soon as the healthcare, in every one of our families, we have chronically ill people dealing with the healthcare system, and every one of us are dealing with this, and it's real, and it has an impact on our mental health. So Patrick, I wanted to ask, what was, if anything, that you could say that was a bit more, when a person goes to the emergency in your research and they're Indigenous, what are some of the things they experience in the research that you have? And then how do you feel these type of experiences are impacting Indigenous people?
Yeah, I'll try to be a good witness to what was shared with us in our sharing circles that Leah Bill led, and in our interviews with physicians and nurses. We heard that people don't want to go to emergency departments, that people will avoid care, so may not seek emergency care at all and simply live with something that might turn out to be serious later. We heard that people are, if they're going to emergency, it's because it's the only choice. It's not just because it's open and convenient. And we heard from people all around the province that having had experiences or stories from the local hospital, and there are specific hospitals that people talk about, but people will undertake longer drives to avoid the nearest hospital. So someone's having a medical emergency and they're still driving much further to go to a hospital, maybe in Edmonton and Calgary, where they might think they'd have a better experience. And so, I mean, that's really harmful, especially we know that because of where hospitals have been built in this province, First Nations patients are already having to drive further to go to a hospital in the first place. And then to have people bypassing the nearest hospital in the midst of a medical emergency, there are many health conditions where it matters how quickly things are treated. So we've got a system this is a major system dysfunction if people are avoiding the nearest hospital. We heard that people expect discrimination when coming into the emergency department. People talked about getting dressed up, even when feeling very sick, making sure. Women talked about putting their makeup on. People talked about trying to find a way to mention their high status job, if they have a higher status job, to try and just be taken seriously and get sort of equitable care that others might get. And then, yeah, we heard about how harmful it is when someone, regardless of what their intent is, somebody might say, when did you have your last drink, if they think that there's been alcohol. So I, as a white person, I might think that's a weird question, but it's not going to cause me to think, it doesn't make any sense to talk about racial profiling of a white guy. So yeah, so when those questions are asked insensitively or thoughtlessly, people then have to wonder, is this a stereotype being applied? Where is this question coming from? Am I going to get good care? So that added source of stress about if something isn't going well, is it because of racism? As a white person, I might just think, someone's busy or they're not very kind. I'm not going to think they're being racist, but that's something that Indigenous people have to deal with. And then there are the overt examples. So in one of our circles, a woman, or just a really lovely woman, talked about being on the gurney in the hallway in the emergency department, and people came and took her information, as is done. Then she said they went away and they were still in earshot and they were making fun of her Indigenous name. And so then she's saying she's laying there sick on the gurney and thinking, what do I do about this? And so when she came to our circle years later, she was talking about feeling badly that she hadn't spoken up to address that in that moment. And I just think, how awful is that? It's not on the patient to have to, it shouldn't be on the patient to have to speak up in those situations. That should never happen. So all of that causing people to leave the emergency department. We know that people leave without completing care much more often when they're First Nations than when they're non-First Nations. All of these disconnects where care can be interrupted and people not get the care they need. And then the impacts later. There's a scholar called Kitchling and Janet Smiley published an article last year that showed if First Nations, or I think their study was for all Indigenous people, if Indigenous people have had negative experiences of discrimination in healthcare, they're much more likely later to not be receiving healthcare that they need because it stays with people. I think that makes sense. If you've had bad experiences, you don't want to go and subject yourself to it again. And I think Bonnie can speak to this from the lived experience perspective or much better than me.
Sure. Bonnie, just in reflection, was there any comments you wanted to add to that on, in the research that you've done, what are some of the things that people experience that are Indigenous as they walk into an emergency room?
Well, and I think it's not just an emergency room. We've done a number of extensive research on cancer, autoimmune disorder with Dr. Cheryl Barnaby. It's published articles. I think that there is a large number of our people that don't have family physicians, and the delay in diagnosis is huge. I know that people with autoimmune disorders in our study with Dr. Barnaby, it was taking up to 3 years to get a diagnosis of an autoimmune disorder. So, we see that in the overprescribing of hydromorphone in the First Nations opioid report. So the report of November 2017, there was I think a 533%. Now, statistically speaking, how do I speak to that number? I don't know, but a major overprescribing of hydromorphone to Indigenous population groups. And so if it's taking that long to get a diagnosis of autoimmune disorder or a diagnosis of cancer, it was taking up to 6 years to get a diagnosis of cancer. And then there's this overprescribing of pain of opioids and not really getting to the source or the true understanding of the cause of the pain. Then we are now labeled as pill seekers or opioid pill seekers when we come into those spaces. But I know when we did those interviews with our cancer survivors, they were begging for a referral to oncology because they knew something was terribly wrong, and they didn't want any opioids. They wanted to know what was wrong. And I can speak, I think, for my mother's case, it took 13 years to get a lupus diagnosis. And, that should not happen, and And then with Dr. Barnaby's study, they had to fail treatments like ibuprofen, and not a lot of doctors prescribe an over-the-counter pain med like ibuprofen in order to qualify for the higher costing drugs like biologics and the DMARDs in our non-insured health benefit, I guess, systems of drug, drugs that we can get paid for. So there's a lot of flaws in the trajectory of care and diagnosis. And I think we have to address all of them, unfortunately. And going to the ER should not be a space where we just go in and we just fall off the charts or anybody's system. I think there should be follow through. And we should get a diagnosis in a timely manner, and like anybody else, right? I mean, everybody says, the earlier you get a diagnosis, the better the outcome. And if we can get fully funded primary care networks and family physicians that are attached to First Nations that really listen and care for our people. I know nurse practitioners, are also a solution, but we need to really focus on that piece, and then we won't see so much of this other piece. So the whole system needs a revamp, and which is really difficult right now because our whole system is, on the brink of exhaustion because of the pandemic and the shortage of nursing staff and all of these other things. We're going to have a huge negative impact going forward in this recovery of this pandemic. So I think we have to act sooner rather than later to address this. And unfortunately, it's not a priority on government systems. So hoping that this research work identifies it as a future priority.
For sure. I want to thank you, and I want to thank both of you for joining us today to talk about mental wellness and racism within the healthcare system and how it affects our people. And I'll just add, after listening to the two of you there, I also think of the trust factor. Like, it's a system that we do not trust as Indigenous people. And I'll include myself in that. I definitely, and Bonnie, I know you feel this, and I know, Patrick, you've heard it from your research as well. It's like we have to maneuver this system and figure out how we're going to do what we need to do for ourselves. And as soon as you said, Bonnie, I had to drive to Calgary, I thought, yeah, how many times have I done that in my lifetime, having to go here and having to go there? And then when we find even a dentist, we find a dentist that is very nice. We tell our friends and our family, this dentist works well, and then they're overwhelmed. The dentist gets overwhelmed, and that's a true reality for our people. And that also is a stress factor on our lives because of the chronic illness that we deal with. Like, I have autoimmune issues, and I've dealt with the healthcare system more than I've ever wanted to in my life. And it started with an ambulance ride 8 years ago. And when the ambulance arrived, just flashbacking back, they literally thought I was on drugs or alcohol. And my mother was there. I actually called my mother before I called the ambulance. And she lives 2 hours south of Calgary. And she had to come and be an advocate. And I waited for her before she got there. And she told them that I am not a drug and alcohol user at all, and that I was one of the most healthy people she knew, and she didn't know what was going on. So that was when the care changed for me. Little did I know I was going to have to continue to deal with the healthcare system because of autoimmune issues. And most recently, my son, he's going to be 20 very soon here, and I've had to teach him how to advocate for himself in the system. And so he had to go to his first physical, and I'm making sure he's, we also do that as Indigenous people. We make sure everyone in our family is also looking after each other and have those points where they're going for regular checkups. And he's definitely young, And sure enough, those autoimmune issues that I have started creeping up for him. And he was actually really ignoring them. But in that, when he did his intake, he was completely shocked that they asked him about what street drugs he uses and about alcohol. And I was in shock as well. And I thought, I cannot hide a reality from him. I can only educate him. So I wanted to share that, and this discussion has brought up those things for me, and we live with these things on a daily basis. So the other thing that we do when we get stereotyped, and a lot of our people are not strong enough, but they internalize and the stigma of this discrimination as well, and it affects them in other parts of their life. Now, with the time we have left, I wanted to ask about what kind of solutions that this research is hoping going to evolve into, and what kind of, maybe, those that are listening, what are the quick wins that the healthcare system and healthcare providers can do today? Also, what are the long-term solutions that people could have? I do know that funders, one of the things I want to state is funders need to be accountable to people, need to have a plan in place on how they're dealing with this before dollars are given over. I'd like to see accountability in that, because there's accountability in other things there. But we'll go to solutions, and then we'll go, when we wrap up in 13 minutes here, well, I just want to have closing remarks from both of you. So first the solutions, and then I'll come back to each one of you. And I'll go to Patrick for this one.
We've got recommendations that we've put together, and those are, it's not published yet, it's revise and resubmit. That means the journal has reviewed it and they've got some questions and suggestions that we'll have to address. But so our recommendations, we look at what are providers doing, what should individual emergency departments be doing, and then the system as a whole. And we really don't want to go after the providers. We know working in emergency departments is very difficult. Many people have the best of intentions, but what opportunity have they had to learn better approaches or ways of speaking about things? So some of the people who interviewed in our study talked about things they do try to do. So one provider talked about saying, instead of just coming out and asking about drugs and alcohol, they might preface it and say, given the symptoms you have or the treatment I'd like to prescribe, it's important. I know if you use alcohol, would it be okay if I asked you about that? Kind of preface it and lead up to it. Just more sensitive ways about talking about these things. Some providers talked about just spending more time to try and, like you talked about, Loa, build that trust, even though emergency is time pressured, with recognizing that people have had negative past experiences and just accounting for that to take a bit more time. For providers to recognize that the system and resources available outside the emergency department aren't always the same for First Nations as non-First Nations people. So some providers talked about, if they know someone has to drive 3 hours to see the specialist, they might ask the specialist to book that person in the afternoon. Just things that are going to make it a little easier for someone to get the care they need. But that's really just a recipe for the individual providers to burn out trying to figure out what every individual needs. So then what are departments doing as a whole to set up referral pathways to work with First Nations health directors like Bonnie to try and address gaps in the system? So at a department level, how are they educating their staff? How are they building referral pathways? And then for the whole system, what are we looking at in terms of some of the big gaps like primary care that we talked about earlier? The Canadian Association of Emergency Physicians also has recommendations for addressing racism and colonialism in emergency care. And we were glad that they cited one of our studies as one of the key guiding documents for that. So unsurprisingly, their recommendations are largely things we could agree with. So there's some hope there, I think.
Thank you very much. And so I will come back to you for closing remarks. And the closing remarks most likely will be three minutes long. And so Bonnie, I want to ask you the same question. What are quick wins that current healthcare providers could do today? And what do you think some of the recommendations will be coming out of the research that you've done?
Well, I think, some of the quick wins is educate yourself. I think you live in a territory that's Indigenous, it's not the Indigenous responsibility to teach you who we are. You know, I think if you were to move and live in a foreign country and you had a desire to live in that country, it would be your responsibility to get to know the culture and belief system of that place. And, you know, because you may be third generation, fourth generation, fifth generation settler into this space, it still is your responsibility to really understand this space in which you live in, and the richness and the gifts that this territory has given you and your family to thrive. And you know, that largely in Mohkinstsis in Calgary, that comes from our Blackfoot people, our ancestors, that cared for this space to ensure that it can give life and sustain life. You know, I think that's one piece, and I know that Dr. Tailfeathers talked about that cultural training and responsibility. But it goes beyond that. It goes beyond a video series of a checkbox of I've watched this video. And I really love the work, and I'm not going to remember the videographer's name, but you would know him. But the video that he did of Making of an Elder, and he really went into an in-depth understanding of this area and the gifts that it had given his family, and got to know the Blackfoot people. And you know, and that's one individual's journey to really understand, you know, this territory and this space. So it's not just about land acknowledgements. It's not just about, you know, going through a cultural training series, but just really, you know, having a good understanding. So when you see a Blackfoot person coming in, you know, that might have long braids, and we as Blackfoot people know who is a ceremonial person just on how they dress and who they are. And, you know, there's witnesses, you know, so in our communities, when we know who those people are, and there's protocols on how to care for those people and how to be respectful of them. And so, you know, Loa, when you found yourself getting asked if you were on drugs or alcohol, same thing happened to me this summer in Cochrane in the urgent care. And I had elevated liver enzymes. I just got into a really severe car accident. I totaled my vehicle. And I went in there because I was not tolerating Advil. And I wanted to really see if there was some more injury that was causing the problems. And what I was met with is, when was your last drink? Do you drink? Do you take Tylenol freeze? And at the end of it, she's like, well, it must be cancer. And I'm like, on what basis? On a one single blood work, you're going to make that diagnosis? You're going to throw that out there so flippantly, you know? So, you know, I think we have to, you know, not only just know the people that we're providing service and care to, but also we have to check ourselves and mind ourselves, and really do self-care, you know, and be a good human being, you know. I think that should always be what we're all striving for. Be the best human being that you can be, you know, and if you're not, then you need to actually take time off and take care of yourself. If you just can't be kind and you can't be the best person that you are, and know when you can cause harm with flippant type remarks like that, and how deep that harm can be, you know. So I think there's a lot of work that we need to do. Bigger things, you know, are on the table, like First Nations health legislation conversations. But we still have to really uphold that initial promise, the treaty right to health, and you know, and develop those allies and those government funders to really understand, what does that mean? Our ancestors put that there for a reason, you know, and they loved us so much and cared for us so much that our ancient, you know, like our ancestral knowledge systems are still very much alive, and they ensured that they would be in 2022 for us. And as I go through them, I'm realizing and understanding how much my ancestors loved us so that we can continue this way of life. And we have a lot to teach the settlers. We have a beautiful life, a beautiful way of life. And if they would give us opportunity, like they did at the Medicine Line vaccine clinic, where we vaccinated non-Indigenous people, is because as Blackfoot people, as the caretakers of this territory, it is our responsibility to sustain life for all things living. That includes settlers. So that is why we opened up that vaccine clinic to non-Indigenous people, is because we care for all people.
For sure. Thank you. Thank you very much. Patrick, I'm going to go to you to closing remarks in a couple of minutes.
Yeah, well, I thank you very much for the opportunity to be here and talk about these results and spend some time with yourself, Loa, and Bonnie. I think even though we're documenting negative things, I hope people will take our study as a sign that people are taking this issue of racism in healthcare seriously, and that it can, be a sign that things are getting better. For providers listening, emerge providers, we hope that this will help to not jump to conclusions and maybe just check yourself and really see patients in front of you as unique individuals rather than as whatever preconceptions might be there. And yeah, just grateful again to have a chance to talk about our work.
Thank you very much. Bonnie, I'll go to you, 2 minutes if you can close.
Well, and I just echo what Patrick said, and I think, this study is not, to point fingers of blame, but it's really to be the beginning of finding those solutions and understanding that it's sometimes those pieces of legislation that are archaic and were meant to cause harm, that are still in existence, they're still continuing to cause harm, that we need to address them and we need to change them. And work together for solutions. But Indigenous people need to be the drivers of those solutions. We need to be the ones that help allies to understand how they can support us. We can't continue to be talked about at tables where we're not in those spaces, and it can't be about money. It has to be about the responsibility of human life and caring for human life in a way that is ethical and humane. And that's just where we need to go.
Thank you. I want to again thank both of you for the hard work that you're both doing. This kind of work and these kind of studies, they're not easy. They're actually energy draining. So I want to thank you. And I also didn't get a chance. I know some of the stuff will be published. So definitely that we could look forward to that. But I do understand too, Bonnie, very clearly that these types of things cannot be done without us included. Solutions are not going to be found without us at the table. I definitely like that. I also like that there was an aspect of ceremony that you guys used, and you also used the entire community and health professionals. So it definitely is a whole approach. I'm in awe of it, and I thank you again that this is out there for our people, for those of us that deal with the healthcare system every day. And I want to say again that today, more than ever, nobody can deny that we actually experience systemic racism and discrimination in the healthcare system. And I want to hold up all the champions like yourself. Today, I would like to thank our WinSpeaker Media staff. I would like to thank our First Nations Inuit Health Branch, our partners in this, and our steering committee from Treaty 6, 7, and 8. And this broadcast will be rebroadcast throughout this month. Thank you, everyone.
All right, and you are taken off. I'm gonna head out, and best of luck.
Thank you.
Because I gotta get out of Candace's way here.
I don't know if Bonnie left. Thank you, guys. You know, I don't know, you're in there. I wanted to ask you, but didn't get a chance to ask you. I know there's a Canada Health Transfer Agreement, and I don't know if there's push from any leadership to get something in there.
Well, right now, I think that it's more the First Nations health legislation that is being pushed. But, you know, writing colonial legislation that's mandated by colonial law is not a solution,
Yeah,
you know, and I think, you know, they have the instructions and the guidance from, you know, the Treaty Right to Health.
yeah.
And, that's not being recognized or upheld, and it needs to be. That needs to be the first go-to.
For sure, for sure. Well, I thank you guys, and thank you, Jade and Jason. I don't know if you guys are still there.